reproductive and sexual health needs between men and women receiving treatment for substance use disorders or other chronic medical conditions. So sexual health needs are defined by the United Nations Population Fund as a state of complete physical, mental, and social well-being in all matters related to the reproductive system. Reproductive and sexual health is not limited simply to HIV testing, but rather it stretches to include family planning, reproductive health, and cancer screenings, contraception, and even intimate partner violence. As demonstrated by this chart, unmet family planning needs for women in their reproductive age is a global phenomenon, in addition to the substance use population. So substance use disorder population faces many barriers to care, such as child care support, unsafe housing. But another important barrier that they face is reproductive and sexual health needs. And this lack of unmet reproductive and sexual health needs are present at multiple different levels. They're present at the individual level, in which patients have reported in the past that they experience transportation barriers and childcare barriers. At the provider level, where there's a lack of communication between providers, and at an organizational level, where there is a shortage of available resources. To demonstrate this further, there was a study conducted in 2019 that found that most opioid treatment programs in North Carolina were required by law to provide some reproductive and sexual health services, but they were non-compliant. Only 53% of these OTP facilities tested for Hep C, while only 39% tested for HIV, and only 68% referred for prenatal care for their participants. So this lack of resources have led to unmet needs such as ineffective contraceptive use and sexually transmitted diseases. So some potential solutions that have also been reported in the literature have been to integrate RSH services into substance abuse clinics. And this has actually been proven to be beneficial in the past and may help overcome some of the barriers that our patients face. For instance, a program in Maryland combined contraceptive services to women using a pediatric clinic and a drug treatment facility. And this convenient access allowed 671 women to be treated over a 4-year period. So research doesn't typically examine RSH needs in their entirety, and usually only has focused on HIV transmission in the past. So our research wanted to examine looking at RSH needs in their entirety, and including more things under it, such as contraceptive use and family planning. Men, in addition, have not primarily been the focus of most medical research looking at RSH services, so we also wanted to include men in our survey, in our project. And in addition, the previous research has not had a socio-demographically similar comparison group who have also used the healthcare facilities in the similar pattern as the SED population. So that's also something we included in our research study. So our primary objective was to compare unmet RSH needs of men and women in the SED treatment center and those receiving care in the chronic medical conditions CMC group at the academic medical center. The secondary objective of our study was to compare patient-reported barriers in the same populations. So we hypothesized that men and women in the SED treatment group will differ from participants in the chronic medical condition group in unmet RSH needs and reported barriers to RSH service utilization. So the methods that me and Geethika had were pretty similar, so I'm going to go over some of the methods that were specific to my study. But we conducted a cross-sectional survey coupled with a retrospective medical record chart abstraction. Oh, I'm so sorry, that's supposed to say chart abstraction. What we had done for the cross-sectional survey measure were include questions about demographics, RSH receipt, RSH need desires, self-reported barriers that the patients had reported on, And this right here gives you a sample of what the survey looked like for our patients that were taking it, and the format of the questions that they had answered. And the chart abstraction measures included us going back into patients' charts and getting their medications list, previous diagnoses, and looking at the most recent visit they had with us and other healthcare facilities as well. Another example of some of the questions that we had asked were for like demographic questions. The way that the questions were worded were, if we were asking patients about how often they were seeing their healthcare provider in the past 12 months, we had defined it as answering at least about once a year, apart from your addiction. How often would you say that you have seen a healthcare provider in the past 3 years? And similarly, discrimination and some of the other things that we're going to talk about in our results had also been asked in similar manners. And so I've provided examples of some of those questions here. For barriers, for instance, we had asked patients to answer either strongly agree or agree to certain statements, which I've also presented here. And for analysis, we had done descriptive statistics that were generated for the SED and CMC comparison groups. And then separately for men and women, the differences between the groups were assessed using the Pearson chi-squared test and the Fisher exact test for categorical variables and student t-test for the continuous variables. And for all analyses, the significance was set to 0.05. So for demographics, we had 275 participants complete the study, and the demographics were generally similar between the SED population and the CMC participants, in addition to them reporting how they were accessing healthcare apart from their SED or primary care providers. The SED group, however, did report more psychosocial disadvantage than the CMC group, for instance, in unsafe housing and food insecurity. But the comparison group reported more prejudice and discrimination in the healthcare setting than the substance use disorder group, which was surprising. For the treatment demographics, the SED population came in mostly for opioid treatment, while the CMC population came in mostly for hypertension and chronic pain. For RSH needs, both men and women in the comparison group were more likely than the SED participants to receive a sexual health exam in the past 12 months, while receipt of other RSH preventative services were generally the same across all groups. The SED participants received mammograms at a much lower rate than their primary care counterparts. And the HPV vaccine, however, was low across all groups. And among men, the SED and CMC groups reported very low contraceptive need, and many of them reported not using any contraception with their partners at all. So the most common barrier that our patients reported was cost. And the second most common barrier that women in our study reported was fear of judgment for drug or alcohol use, while the second most common barrier that men reported was knowledge of RSH resources. And so we asked our patients whether they had desired RSH services to be provided at our addiction center, or if they desired a referral. And across the board, they had expressed desire for RSH services to be provided in person at the addiction treatment center. And the most common desire that they had was for Hep C testing. So the major takeaways were that integration of RSH services into SED treatment centers is desired by participants and a necessary component for improving their overall health and recovery. And participants in the SED treatment centers and those receiving treatment for chronic conditions had similar RSH needs, indicating that this is actually a problem of social determinants of health. Social determinants of health can play a major role in these deficits, but some RSH needs were more pronounced in the SED than the CMC participant group, and RSH needs and barriers to care differed between men and women, and so that needs to be taken into account when we are treating them in the future. Any questions?
Great job, Shali. I just want to shout out Shali. She got the summer fellowship last summer, so that's what this project was from, when she got the Dean's funding after her first year. And this manuscript has been submitted. It is in review. I don't remember, where did we send it, Bhushan, or have we not?
Substance use and misuse.
There it is. There it is. We had to find a different journal. So we are waiting to hear back, but it is completely done and the data looks really great. So I think you did a great job, Vishali, highlighting the specific gaps in knowledge that this study addressed. Does anyone have any questions for Vishali about her study?
Can I just say that I thought that you did a really, really good job, and I love that the intersection between pediatrics and OB-GYN, that you were able to do that. I think that's awesome. And how addiction kind of touches everyone's lives in lots of different specialties.
Thanks. Yes, I agree. And Vishali, I know we've talked a little bit, but I just wanted, you know, when we had our hypotheses, right, of what we thought we were going to see, and I know that we ended up having a few things that came out in the data that did not necessarily go with our hypotheses, such as the contraception drama. Do you remember our issue with the ages? So you want to tell people what happened with the data? I think that was just a good learning experience for me, thinking, gosh, you know, when planning a study, think about how your patient population that you're targeting. So if you want to tell people a little bit more about the contraception findings that we found in the study, which luckily for us was not meant to be the primary outcome, because they're already, if you look at anything reproductive sexual health related in addiction, it's always contraception. That's pretty much what anyone has ever published on, but no one really has done a lot for things outside family planning. And we know that's just one piece of what women come to see the doctor for. So do you want to tell people about what happened with that data?
Yeah, I can definitely explain my understanding of what happened. But I know that there was a discrepancy in the age of the participants that we had gotten. And I believe that the primary care group, and the women in particular, they were a little bit older than the participants who were in the SUD population. And because of it, when we went to look at women who fit the, because I think the way that we had defined contraceptive need was women who were still in their reproductive age, and a lot of women did not qualify who were in the other group. And so when we were comparing that data, unfortunately, we just didn't have much to compare to. I might remember it wrong, but I think it was like we only had like 2 women in the other group. And so it definitely, because I guess we hadn't controlled for age when we were comparing the 2 groups, did affect the way that did affect our contraceptive data.
Yeah, I thought that was a good learning experience to me, because I didn't even think about that when we planned the study. So this, you know, the population of interest was Motivate. That's where the study was conducted, was at the Motivate clinic by passive recruitment. So that meant that Annabeth and Lori and all the lovely students that were helping them out, you know, were in the waiting room, and people elected to do the study. We didn't actively recruit them. And then our comparison group, where we planned, was from the ACC clinic. So, you know, the Nelson Clinic on the 2nd floor with all the primary care clinics that the residents run. And the goal, our whole thinking of that was that we wanted to find a patient population that had similar sociodemographics, you know, on paper, similar social determinants of health that they might face, so we can really see what is the addiction part. How is that one variable, as much as you can in observational data. But we didn't think about age. It's such a simple thing. We thought about social determinants of health. We thought about all these other, you know, we were trying to be really comprehensive in how we matched our 2 populations on all these other variables, but not age of all the simple variables, which led to our contraception findings essentially not being useful at all. It was fine for the paper because that was not supposed to be the primary focus. We had so many other reproductive sexual health services, but it was a good lesson to me to thinking, okay, next time you want to pick a comparison population for your study, you know, I always was taught in all my study design classes, your comparison, your control group is always the most important thing you have to choose or make decisions on when you're designing a study for, and this was an obvious, you know, this was an example of that, how our comparison group, you know, had this problem in the age differential. And potentially what we could have done is try to oversample a younger population for the women, so actively recruit them. We would have had to change the protocol, you know, in the IRB for that, in that population. But if we had known that ahead of time or done interim data analyses, we could have potentially caught that problem and fixed it in the data collection phase, because we can't just go back and get more data now. So I'm just sharing this so other people don't make that mistake in the future that I did when we were doing this data. But it was an example of what we didn't see it till the data analysis stage, but there's opportunities in a study design that we could have done earlier.
Yeah, I went back to the table so that I could show everyone that there was like around a 10-year age gap in the means of the women in the primary care group and the addiction treatment group. And so that's where the problem kind of arose from.
Yeah, lessons learned. Great. Go for it.
Vishali, I was kind of curious. You mentioned that I think cost was one of the main barriers in one of the groups. So were these people? Did they list, or did you see if they were? Did they have Medicaid? Or are these like uninsured, totally uninsured people? Or
we actually have the insurance data right here. I didn't highlight it in the initial presentation, but I can read it out.
okay.
So most of them, I think a majority of them had public insurance, and I would say that like around 30 to 40% had no insurance.
Wow. Wow, that's high.
Mm-hmm.
Okay.
Yeah, we were surprised by that too.
Right. With the Virginia Medicaid expansion.
But this had happened, this study was completed like really right after Medicaid expansion happened.
Okay.
And so a lot of this, I don't think they caught, a lot of patients still hadn't gotten access to it yet.
Okay.
Well, just to end, this study, one of the primary objectives for the initial study was to do a needs assessment at Motivate, you know, to see what type of reproductive sexual health services patients at our Motivate clinic may want. So in the future, when we're able to expand the clinic and be able to offer more reproductive sexual health, like we didn't have, you know, a nurse who knows OBGYN at that time and all those things. So we were kind of planning on, you know, having the personnel and the space in the future to be able to do things. So this data is really helpful because we are working towards that at Motivate. You know, now we have, you know, we have Kyle and we have Margie, we have me, there's 2 other OBGYN doctors coming on, et cetera. So we're working towards, at least with the people, not necessarily the space yet. That was delayed because of COVID. So this data will be helpful when we get to the point at Motivate where we can do some more stuff potentially next year. I'm planning on taking it to the clinic and saying, gosh, look at all these things that the patients here say they want, and they want to do them here. They don't want a referral somewhere else. And look, now we have the providers, the nurses and the doctors to do it. What can we tackle first, right? And it might not be contraception. That's what everyone thinks about. You know, that's one thing that we can do, but that's not the end all be all. So we're excited because this data will actually be able to be used in the future. At least I'll make sure it is, to inform what we do at Motivate for our patients in recovery. So we're excited about that. So anyone who's sticking on, you know, like Carrie and such over the next few years and quality improvement projects, there will be lots of opportunities for them based on this data serving as kind of a pre-data for potentially a pre-post data, like quality improvements research study in the future. So we're excited about the possibilities. So great job, Vishali. So we'll go on to Geetika now, whose study is somewhat similar, is kind of under the umbrella of reproductive sexual health, and used a similar study design with our comparison group and the men and the women. So kind of going where no research has gone before, including all of those different groups and comparing them.
All right. Can everyone see this okay?
Yes.
Awesome. All right. Hi, everyone. I'm Geetika. I'm also a rising M3. I'm in the same class as Vishali. And today I'm going to be talking about chronic pelvic pain and sexual dysfunction among females and males in treatment for opioid use disorder. I'm definitely interested in women's health and the clinical and research applications of it. So when Dr. Martin presented like the chronic pelvic pain intersection with opioid use disorder, I was definitely very interested to work on this project. All right, so just as some quick background, many patients who are in treatment for OUD have co-occurring medical factors such as chronic pain, and having that can predispose patients to treatment dropout and compromised outcomes overall. And for a lot of patients, having chronic pain was an antecedent medical condition for the development of their substance use disorder. Most patients who are receiving MOD have at least one chronic pain condition, with prevalence as high as up to 61% in certain patient populations. So chronic pelvic pain is one specific subset of chronic pain that is definitely underreported, but it is very prevalent in both men and women. So the incidence of CPP is common with almost 26% in females and up to 16% in males. The definition of chronic pelvic pain does vary between sexes though. So ACOG defines chronic pelvic pain in women as persistent non-cyclic pain that originates from the pelvic structures for more than 6 months duration. Associated CPP symptoms in females also includes pain with sex, unexplained itching, and also pelvic cramping. In males, the NIH describes chronic pelvic pain as genitourinary pain that lasts for up to 3 months without any identifiable pathology or an infection. And in males, the main chronic pelvic pain domains include urogenital discomfort, sexual dysfunction, and urinary tract symptoms. So in terms of chronic pelvic pain and sexual dysfunction, as you might think, they definitely do go hand in hand, and that can impact emotional status and overall quality of life in these patients. Certain cohort studies have reported erectile dysfunction up to 55% of males with chronic pelvic pain, and there are lower FSFI scores in females with lubrication pain and total score domains as compared to control groups. In terms of chronic pelvic pain and opioid use disorder, there isn't a whole lot of data, and to our knowledge, the prevalence of chronic pelvic pain in an OUD population is unknown. The existing data we did find is, like I said, it's very limited, but when it's reported, it does suggest that substance use is more prevalent among patients with chronic pelvic pain, and that women specifically with chronic pelvic pain may potentially show higher rates of substance use. So it's definitely important to close this specific gap in knowledge as it has not been previously reported in order to better manage patients with this potential comorbidity. So the objective of this exploratory study is to compare sex-specific prevalence of chronic pelvic pain and sexual dysfunction between individuals receiving buprenorphine for OUD and a comparison sample of patients receiving treatment for other chronic medical conditions. So Vishali went over some of our similar methods, but I'm just going to briefly go over some of the specific methods for our specific study. So in females, like I said, we had different definitions for chronic pelvic pain in males and females. So for women, we use the BPI and existing CPP literature to screen for chronic pelvic pain. And an example of a screening question was, during the past 6 months, have you had pain or cramps in the pelvis that has interfered with your daily activities? So answering yes, met clinical criteria for CPP, and there's a bunch of other questions down there that I will not belabor and read to you guys. In males, we use the BSFI and the NIH Chronic Prostatitis Symptoms Index. An example of a question for the males to define CPP was them answering sometimes for at least one body part, such as the rectum, testicles, or below the waist. For pain type and severity, we also use the BPI, and participants rated their severity of pain on a scale of 0 to 10 for different genitourinary scenarios. So for example, we asked for pain with urination, bladder, bowel movements. In females, additional specific experiences included pain with entry during intercourse and pain with tampon insertion. And specific questions we asked for males were pain in the testicles or pain during urination. For pain intensity and interference, we also use the BPI on a scale of 0 to 10. And we also assessed interference of chronic pelvic pain with certain factors such as general activity, mood, and sleep. And this was asked the same way for both males and females. Sexual dysfunction, we use the FSFI for women and the BSFI for males, and we took their total score to see if they were considered to have sexual dysfunction or not. Unfortunately, I don't have that data to present to you right now. We're still working on getting those numbers, but I just wanted to briefly mention it here. So like Vishali said, we also used the Pearson chi-squared and Fisher's exact for categorical variables and t-test for continuous, and we also set the significance to 5%. So demographic and psychosocial characteristics. So again, similarly to Vishali, most participants identified as Black and the mean age was 50.7 years. Almost half of the participants had a psychiatric diagnosis and or a medical comorbidity. So if you look at this slide right here, we can see that in both females and males, there was a significant proportion of OUD population patients that did have PTSD and a medical comorbidity. And if you look specifically at the male side, they were more likely in the OUD group to have coexisting depression, anxiety, bipolar disorder, and or a pain comorbidity. And that was not seen in the female group. So for the CPP measures, there actually wasn't a significant difference between groups, and only a small minority of females and a third of males met criteria for CPP. But with that being said, there were more pain types and pain interferences in the OUD groups compared to the chronic medical conditions group. So in both cases, you can see that OUD females and OUD males rated their average pain to be higher than those in the chronic medical conditions group. We also looked at specific pain types. So OUD females rated the highest pain type specifically with menstrual related pain, and males reported the highest with testicular pain. And lastly, with their pain interference, females reported the highest pain interference with their mood specifically, versus males in the OUD group reported the highest interference with their sleep, enjoyment of life, and sexual function. So that's summarized again in these tables where you can see that OUD females reported the highest pain indices with menstrual pain, and males reported the highest in the OUD group with testicular pain. Oops. In terms of the interferences, like I mentioned, women in the OUD group had the highest pain interference with their mood specifically, versus males showed the highest interference of their chronic pelvic pain with their sleep and overall enjoyment of life. And I forgot to highlight it, but also their overall sexual function. All right, and one exploratory item we asked was to gauge the influence of CPP with subsequent substance use and those relationships. So participants were asked an exploratory item. When my pelvic pain is worse than usual, I am more or less likely to use drugs or alcohol. So we found that OUD males were more likely to report using drugs and or alcohol during their chronic pelvic pain exacerbations, and they were more likely to report that the use of drugs and alcohol relieves their pelvic pain. We didn't see those significant relationships in women, but we think that's because we had a pretty small sample size. But if you look at just numerically, women were in the OUD groups were still more likely to report that they would use drugs and alcohol more likely during CPP exacerbations, and that they were more likely to report that the use of drugs and alcohol relieves their chronic pelvic pain. All right, so just as a brief discussion, the three main findings I wanted to highlight was that while there was no significant difference in CPP prevalence between the OUD and chronic medical conditions groups, the OUD groups did report higher average pain indices and pain severity. Females reported the highest pain severity with menstrual pain and the highest interference with their mood, versus males reported testicular pain to be the most severe and reported the highest interference with their sleep, enjoyment of life, and overall sexual dysfunction. And OUD males were significantly more likely to report using drugs and alcohol during CPP exacerbations. So I just briefly wanted to mention that we know that CPP in these scenarios were shown to impact things such as mood, sleep, and enjoyment of life. And in the literature, all three of these things can interfere with opioid use, the use in general, and also treatment outcomes for these patients. So I found some studies that talked about how negative affect and mood in females can serve as triggers for sustained opioid use and treatment relapse. And sleep, as I mentioned, was most significant in the male groups. And that showed that, or literature has shown that sleep interruptions can increase susceptibility for opioid use due to the potential disruption of the brain reward system. And lastly, there was a significant connection between CPP exacerbations and subsequent alcohol use by the OUD males. And the experience of OUD treatment during OUD treatment does facilitate opioid cravings and subsequent relapse to opioid use. So given all of these findings, and this finding specifically, it shows that chronic pelvic pain and OUD management can definitely influence each other. And therefore, chronic pelvic pain may be an important consideration in tailoring comprehensive treatment approaches for patients that are currently enrolled in OUD treatment. Some of the limitations, so some of these are similar for Vaishali and I, and one is that the study was conducted just at VCU and at the Motivate Clinic, and that can limit generalizability. Because all of this was determined by survey, there definitely might have been social desirability bias, which could affect our results. And also, like Vaishali mentioned, the males and females in the chronic medical conditions groups were older than our OUD males and females, which can affect our age-matched controls. And three limitations specific to my study were that the sample size was pretty small, especially for some of the female variables that we looked at. There were two different definitions for CPP, and we had to use different screening tools because of that, and that can definitely limit our ability to determine prevalence between genders. And my specific work is just exploratory only. So these are some of my references, and thank you so much.
Great job, Deetika. Her abstract also, both of these abstracts are accepted at ACOG, so we're excited about that. And so it was, I think this study, you highlighted one of the main things I think that has come, we've been talking back and forth, us and Lori and such, as the measurements and how when you're trying to include males and females in one study, and it's not, and you're trying to make sure you recognize that, and you're trying to elucidate sex-specific impacts or sex-specific health outcomes. It can be quite challenging though, because the measurement tools can be different. And so it's ironic though, because we're like struggling with there being two different measurement tools for this health outcome of chronic pelvic pain and the sexual dysfunction, and what do we do in that in research. But then on the addiction side, there are no sex-specific tools at all. So it's kind of ironic, you know, that's what part of my career is working towards, is trying to see how can we integrate sex and gender into how we deliver substance use disorder treatments. And so it's a little ironic because we like have it for chronic pelvic pain and sexual dysfunction. We have those tools that are, you know, that are tailored by one sex. And it's like too much data, you know, it's like we have too much good data for each sex specific, where we have like the complete opposite lack of anything sex specific in the substance use disorder treatment side. So I think it's just been this weird conundrum that I've been dealing with in my head. Like, gosh, this is what happens when you have all this great data. You have too much. I'm not used to that in the substance use disorder treatment world. Does anyone have any comments or questions for Geetika as she's preparing to present at the conference soon? And also finish the paper.
Hi, Geetika. I just wanted to make one small suggestion. I thought your presentation was really good. Just remember to highlight your strengths as well, because I saw your list of limitations, but remember to highlight your study as well.
Good idea. Yeah, should definitely do that. Thank you.
That is a great piece of advice, Deshonda. Thank you.
No problem.
I have a general question that maybe needs like a longer discussion at some point, but is there a way to control for like biological sex differences versus like societal gender differences? Like, for example, is there a if a difference between males and females is because of like something, you know, in our like sex differences versus like how society treats us, or like, you know, trauma specific to females versus trauma specific to males, etc.
That's a really great question, Carrie. And you get at the core of the problem with sex and gender is that, yes, you can do that. But the data does not exist to be able to do that yet. And actually many areas of health, because you have to measure both sex and gender identity, and then you have to piece apart the two. And we're at the point where sex or gender, neither are either being included or have been historically included in research in a lot of different areas of health. And so you have to have that preliminary data to base your next studies, to know how to do a power analysis and things like that. So yes, you can do that. How you do it, I don't know, because the addiction literature isn't there yet. But there is a push definitely to be able to disentangle the sex and gender, recognize where there's intersection between the two, of course, but then there are components that are specific to one variable or in the other. Just to put in perspective, you know, it hasn't been that long, I don't remember what year it started, but it hasn't even been that long that the NIH has required sex to be included as a biological variable in its research studies. And so young people, like, we think of like, oh, shouldn't you have it in there? But older researchers, like, that's a new thing that they have to think about. And now there's a whole section when you submit NIH grants that say how you're including sex as a biological variable, essentially. But that is one of the newer requirements by the NIH. So it kind of just shows kind of the lack of attention that it's gotten in medical research. I think that highlights it, like, oh, that's the newest addition, is that in the life course aspect to the NIH. I'm going to put in the chat like my favorite paper that I've read that gets at the sex and gender aspect. It's not specific to addiction, but I'll put that in the chat. And it's a really good, easy to read from the Lancet that really was trying to get at exactly what you're saying, Carrie, and trying to get more researchers to do that, kind of integrate sex and gender both into their research. For this study in particular, we tried to assess sex and we tried to assess gender, but there were no gender minorities that participated in the study. So everyone identified as cisgender. So we weren't able to do that in this small study here, but we tried. And so to get at it, at least from a variable perspective, to try to get both. I know that's just scratching at the surface to measure the variable, but that's just one example of the kind of the base model. What you can try to start to do is at least assess both variables, so you can have sex and gender and have both of those like in your table one. I know that's not getting at the problem, but it's at least the first step that we're not even there at. Anyone else have any questions about the data?
So I know we're running closer to time, but some of the self-report measures, did you notice, I noticed in some that there was a lot of variability and the standard deviation was pretty high. I think, what was it, the pain interference index? Or is that common with other studies also where there is a lot of variation? Or I don't know if it's a sample size that could have contributed also.
Yeah, I think a lot of the issue was our sample size, specifically for the females, because the ones that qualified, I think Lori highlighted at some point, but the sample size definitely got very, very small when we got to the pain interference questions, and some of the N was only like, I want to say less than 10 participants. So I think that's why you see that variability.
That's a good point.
Yes, because the problem with Geeticas is that it's only the participants only went down to those specific domain questions if they met criteria for chronic pelvic pain. So yes, that's what we ran into, is that you only answered all the nitty-gritty questions if you met criteria.
Yeah. And I think it was easier for males to meet criteria given our specific definitions for males. For females, we only had those two main questions, versus for males, it was like, do you feel pain in any of these areas for at least 3 months? Versus for females, it was just a yes or no binary question for two of them.
Just the last point about the whole discussion we're having about sex and gender differences, and also just recently in basic science, there was a study that came out to highlight that most of the studies in basic science have only dealt with male mice and not female mice. So and even I was listening to a talk where even studies that are doing like drug studies, when they talk about pharmacological trials, they don't discuss the gender differences, they just report data together. So I think there is a push in terms of looking at sex and gender differences, but it's taken a while, but hopefully people start reporting that more.
And then you do wonder with the differences in the sexes and how we are expected to respond, like how much pain is considered, that's just normal, you're a woman, you're going to have that, and we just accept it and go on. Whereas a man, if they were maybe having that pain every single month, they might not put up with it. I don't know. They don't have to put up with it. So it is interesting to see the differences in our own expectations as well, and how we were raised in our various cultures for what is considered just part of being a woman.
Yeah, but I mean, generally also research has reported women and men differences with reporting pain too, where women are more tolerant in the pain aspect. So that differences in chronic pain has always been there. So, and then you compound that with other differences, it just, everything kind of adds up.
Interesting.
Mm-hmm.